I'd like to formally welcome you to our webinar, Integrating Clinical Analytics into Your Continuum of Care. Our speaker today is Mark Johnson. Mark is a Senior Director at Iatrix Systems. Mark joined Iatrix Systems in 2007 and has served in software support, implementation and development roles, along with sales and customer service duties during his time with Iatrix Systems. Mark's nursing background includes psychiatric, cardiac, and oncology practice. Mark is currently serving on the board of directors for the American Nursing Informatics Association and has previously served on HIMSS national committees and task forces, including the Connected Patients Committee and the PGHD Task Force. So now I'll turn it over to Mark to get us started.
Thanks, Amanda, and thanks to everyone for taking time out of your busy day to be a part of this discussion that Iatrix Systems is leading around clinical analytics, data at the right time, at the right place, to the right individual. And I'll unpack a little bit more of that once we get through this. So again, thanks for taking time out of your day to take a look at this topic that involves regulatory requirements, clinical data, real-time monitoring, surveillance. Those are some of the key words we're going to use today in our discussion. Real quickly, let's have a roadmap of where we're going to go to give you an idea if this is the right discussion for you. We certainly hope that you spend some time with us today and listen and join in the discussion. But this is what we're going to focus on. We're going to talk about regulatory requirements that might necessitate a real-time patient data monitoring strategy, describe how some of these, there are clinical challenges around that real-time data monitoring. And then third, we're going to discuss how some successful hospitals and providers are using real-time data monitoring and collaborative best practices to address sepsis management and readmission risk strategies. So those are two regulatory requirements, programs that we're going to focus on today: sepsis management and readmission risk, inappropriate readmissions. So let's jump right in. So why should you be talking or thinking about a strategy for monitoring in real time? You probably have some good ideas. Right off the top, some top 5 would be to improve patient care. If I'm able to monitor my patient closely and in real time, I can react when there are changes, initiate protocols, alert a team that coordinates care around a particular diagnosis or situation, which in turn improves satisfaction. Better patient outcomes from better patient care leads to better satisfaction, which leads to better quality scores, better patient satisfaction scores, and then ultimately it leads to everyone in the community knowing how well your hospital takes care of patients and takes care of the bottom line, which will make your CFO happy, and that's improving reimbursement. So these are some of the things that we're going to talk about today. Is why should I be thinking about tracking patients in real time, having that data to the right person at the right time and in the right way. Of course, if it were easy, everybody would be doing it. So there's some challenges that we need to address. How do I know which patient needs A, B, or C intervention? We've got 200, 400, however many inpatients you have. You've got nurses on certain nursing units that might have 6, 7, even 8 patients at a time. While they have a nurse extender, many times there's a lot of data being collected, so it's a challenge to identify which patients need which intervention at what time. The data collection can be disconnected. So vital signs might not be going into my EMR automatically. Maybe a nurse extender takes those vital signs and those intake and output data points, and they don't get into the EHR for quite some time. That delays those decisions that need to be made. And then that point of care, integrated workflow, those are those things, like I just said, with vital signs and intake and output, the data collection and then the real-time entry into the medical record can sometimes be disjointed and disconnected. So if it were easy, everybody would be doing it. So these are some of the things that we have to think about when we're doing real-time monitoring. What are some of the challenges? How do we work around these things? So as I mentioned earlier, we were going to talk about readmission and we're going to talk about sepsis management in this discussion this afternoon. So let's focus on readmission. The HRRP, Hospital Readmission Reduction Program, came out of Obamacare a few years back. CMS said, okay, we're going to start looking really close at inappropriate readmissions. So they started this program up, and how are we doing? Not so well. As you can see, in 2015, 799 hospitals out of 3,400 that were participating didn't do well enough. Of 799, beg your pardon, of those 3,400 did well enough to avoid a penalty. So it's a substantial number of hospitals involved in the program did not perform well enough. So got to do a better job of tracking those readmissions, keeping folks in the outpatient setting, getting them the appropriate treatment they might need as opposed to an inpatient admission. When folks do that, and they give them the appropriate care in the outpatient setting, they keep the patients out of the inpatient arena after a discharge. Within that, there's a 30-day window that you're always monitoring. A Harvard University study found that higher rated hospitals do in fact have lower mortality and readmission rates than their lower rated counterparts. And what that's talking about really is focusing on those HCAHPS scores. So that's sort of anecdotal, that if a hospital is doing well and providing the right care in the right setting, then the patient satisfaction scores are going to go up. So those are just two reasons right off the bat of why you should be tracking patients who have been discharged, and we're going to unpack this a little bit more, and making sure that you have an awareness of who's been discharged, who's a Medicare patient, who has a certain diagnosis. There are a lot of points and a lot of dots to connect. So that's why you need some type of application, some program, some strategy to keep up with all of those patients. So as I mentioned, the Hospital Readmission Reduction Program, HRRP, it looks at, and this has grown, this list, it looks at a list of diagnoses that for patients that are Medicare that you need to track that 30-day window. Were they inappropriately readmitted after a hospital inpatient discharge? And if so, there could be a claims penalty when you submit that claim back to CMS if they were inappropriately readmitted. So some of those diagnoses as of today in the current program we're looking at is AMI, heart failure, pneumonia, COPD, total hip, total knee, a CABG or coronary artery bypass, aspiration pneumonia, sepsis coded with pneumonia present on admission but not including severe sepsis. So they're not tracking severe sepsis, but it's interesting that severe sepsis or septic complications are involved with more inappropriate readmissions than any of those other diagnoses. And as of today, right now, sepsis is not one of the diagnoses that CMS is monitoring for their Medicare patients as part of HRRP. And we'll talk a little in great detail about sepsis as we walk through this discussion. There's also another all-cause hospital-wide program that's part of the inpatient quality reporting requirements that's not the same as the HRRP. So if they don't get you with these diagnoses, they may get you for some other all-cause hospital-wide as part of the inpatient quality reporting program. So bottom line, you really need to focus on patients who are being discharged. Do they have appropriate discharge planning? Do they have outpatient pharmacy medication access, in-home care? How are those activities of daily living being handled? Those things need to be coordinated so that you can keep those patients in the appropriate setting so that you don't have that penalty when you submit the claim. What's interesting about HRRP is this is so retroactive. Right now, for the fiscal year 2018 that we're moving into, they're going to be looking at admissions and discharges from July 1st, 2013, yes, almost 5 years ago, through June 30th, 2016. So although those admissions and discharges and readmissions have already happened, you can't do a lot about that now. You still have to have a forward-thinking, forward-moving strategy to keep up with all of those patients so that you can have that awareness of what's going on after they've left your inpatient facility. So let's unpack a little bit more of how things are going for hospitals who've been involved in this program. And 2013 was the first year of the penalties. As you can see, the penalty started out with a lower bar, 1%. However, 8% of hospitals paid that 1%, which is 290 million. 2014, the penalty went up to 2% and 0.6%, so the penalty total dropped a little. But then in 2015, that penalty hit 3%. So you're talking $428 million claims penalty from CMS, money that they're withholding on reimbursement for care for Medicare patients. And again, that's, it was the 2013, but they were looking back previously. So yes, this does happen in the past, but you have to have a strategy moving forward so that as this program continues, you're going to have that bucket of patients be involved in your penalty calculation moving forward. Now, there has been some complaints from hospitals, especially those in certain socio-demographic areas, saying, hey, we are a safety net hospital. We have patients with low education, with low access to providers in the outpatient setting. We're here as a last resort. We may have a lot of inpatient discharges and readmissions in that 30-day. We take a hit because of where we are and the type of provider we are in our community. So as part of the 21st Century Care Act that you may have heard about last year between the election and when the new Congress sat, they're taking into account what safety net hospitals have told CMS is, hey, you're inappropriately assigning a penalty us when we're a safety net in the community, and we're going to have some of this. So maybe give us a different formula, have a different calculation for us. So they are taking into account. So if you are a safety net hospital, your formula is going to be a little bit different than someone who's not a safety net hospital. So that should help offset some of these penalties that some of the safety net hospitals are taking in. Regardless, there is still a substantial penalty that's involved. As you can see, amounted to 125,000 to 164,000 penalty per hospital on average. So again, I've been saying these are claims data. This is how you get this information. They look back on those CMS Medicare claims. They look to see if they were inappropriately readmitted. Do they have one of those diagnoses that they're tracking? So as part of fiscal year 2018, which is starting up in October, CMS proposed, and they have since finalized, a new program that they want to start, a voluntary program, I should say, to test a new hybrid hospital-wide readmission measure. So what they want to do here is not only look at the claims data, but also, now that everybody's got an EHR in the inpatient arena, just about everybody, thanks to the high-tech, what we've done for meaningful use, and everyone's gotten on board, they want to also collect some data elements from the clinical record, primarily vitals and lab results, and look at that to see if there was some other factor that they can make a decision on. And that's why this is a voluntary program right now in 2018. But let me tell you, the plan is, as of 2021, in just a few years, they want to make this required. So they're asking for volunteers at this point, and they want to build a data set so they can look at all of the data clinically to see if there was something when a patient went home, hey, maybe vital signs and labs were fine, but something happened and brought them back, and maybe that would be something to balance out in the formula for calculating any reimbursement penalties. The good news, as I mentioned, around high-tech and meaningful use is JAMA has also looked at hospitals who are involved in value-based purchasing programs, meaningful use, accountable care, bundle payments, some of those alternative payment methods from CMS, and they have found those hospitals involved in those programs are doing better at readmission reduction than the hospitals that are not. And you might look at this and say, well, yeah, that makes sense. And the primary reason it makes sense is because those hospitals are more than likely to be progressive with their strategy around their electronic health record. So if you're doing meaningful use, you have an EHR, you've got those data points, you can look at a patient longitudinally and make better decisions around discharge planning, outpatient setting, follow-up treatment, all of those things. So The good news is if you're in this discussion today and you're a meaningful use hospital, more than likely you're doing better, according to what JAMA has looked at. You're doing better than your counterparts who don't have an online medical record, or maybe they don't have one in the ED, or there's certain parts that they're not involved with. They're not as progressive in their strategy. So there is some good news there, in that our hospitals that are progressive in their strategies and alternative payments are doing better. So we've walked through just a high-level review of why you should be looking at readmissions, tracking your patients with certain diagnoses as part of this hospital readmission reduction program, or in general inpatient quality reporting. So readmission risk is a strategy that can be addressed with real-time data monitoring. For example, if I'm a Medicare patient, I'm over 65, and I go home with a total knee, why not alert someone that a total knee patient may be discharged tomorrow based on a physician note or something in the EHR, so that your planners, your nurse navigators can coordinate, okay, we're going to send this patient to this subacute rehab, or they're going to home care and they're going to have home health. All of those coordination efforts need to take place, but why not get that individual who's being discharged on a tracking radar, so you can watch as they go from T-30 down to T-1. Nurse navigators can check in, making sure they're doing their follow-up appointments, get something like an appointment scheduling feed coming in, so you can see if they missed an appointment or they didn't schedule an appointment. Those are the things that we're talking about, things that should be as part of your strategy. And that's where analytics can take all of those multiple data points, bring them together, make them easier to understand, and in essence, easier for someone to track and monitor, keep up with your patients who have been discharged, who could possibly incur a penalty if they were readmitted before that 30 days has elapsed from their discharge. So that's readmission. Before we move over to sepsis, I want to turn to Amanda, now that we've been a few minutes into the discussion and it's given you an idea of where we're going, to see if there are any questions from the group that's joined us today.
Okay, I just want to remind everyone, if you do have a question, just enter it in the questions pane of your control panel. And Mark, we do have one question here. Do you know which set of admission claims will the HRRP be reviewing for the next fiscal year?
Yeah, I do, and that was what we were talking about a few slides back. So fiscal year 2018 will start October 1st, 2017. And just like the years prior, CMS is looking at previous year's claims. So it's going to have to be retrospective. It's not going to be real time, at least yet. Things may change as we move forward. So for 2018, they'll be looking at July 1st, 2013 through June 30th, 2016, a 3-year period there, almost 2 years back. So each year it's always looking retrospectively. So that's why it's important for you to have a strategy in place to continue to monitor patients.
Okay, thank you, Mark. That's all the questions we have at this time.
All right, thanks so much, Amanda, and thanks for that question. So let's move over to the next part of our discussion, talking about sepsis. Most likely, if you're involved with any sort of the quality or core measures or process improvement at your facility, as a provider, you know about sepsis management, the Surviving Sepsis campaign. We're going to talk about surveillance around sepsis management and why that should be a tool you should consider as part of your clinical analytics strategy and surveillance. Sepsis is important to me, not only from a practitioner, but from a patient standpoint. Maybe it was 2002, so that's 15 years ago now. It doesn't seem like that, but it does. Time goes so fast. I got a nosocomial infection while I was working at a facility, and I was in the middle of my 12-hour shift on the oncology unit working with neutropenic patients. And if you know about neutropenic patients, their immune system is compromised, and they're very prone to getting infections that you and I deal with every day with, and we don't end up colonizing and having an infection. So I got an infection from most likely from a hospital patient contact, got very sick while I was in the middle of my 12-hour shift, 104.3 temperature, severe pain, could not walk, shortness of breath, all of those signs that indicate their sepsis is, and I'm going down that sepsis spectrum. All of that was occurring in the middle of my shift, and it occurred very rapidly. I was able to get to the emergency room. I was able to get appropriate care, some broad spectrum antibiotics, diagnostic imaging, all of those things, so we could isolate where this problem was, where the source of infection. I ended up spending 9 days in the hospital, had to have some exploratory surgery done, a drain placed. It was really a nightmare. It made me a much better nurse, very empathetic for a patient situation, and it put sepsis in the front of my mind probably for the rest of my life, because I really thought I was going to lose my life and scared my family and my wife and kids really bad. So sepsis is something that can escalate very quickly. Just like in my case, the vital signs were changing rapidly. And as I mentioned in the beginning of our discussion, if you're not getting vital signs data into your EHR immediately, there's a gap in the ability to make a clinical decision to respond appropriately. And sepsis is a great case study to look at. Why do I need to have continuous monitoring, surveillance, information coming in, being machine learning, analytics, whatever term you want to apply for what's going on, to look at that and give me some information as a clinician so that I can respond appropriately. But very quickly, sepsis is the body's overwhelming and life-threatening response to an infection. It's almost like the body's overreacting to that infection. So you start seeing those things like blood pressure changes, lab values start changing rapidly. And that's why you need to intervene very quickly with sepsis. Symptoms of sepsis, this is a great mnemonic tool. You know, sepsis, shivering, extreme pain, pale or discolored skin, sleepy, difficult to rouse, confused, I feel like I might die. That's my quote. And then short of breath. And before we move on away from this slide, I will point you to the Sepsis Alliance. They're a great resource, nonprofit, for getting some information around what is sepsis, surviving sepsis campaigns, the protocols that are out there, and some success stories as well. There are a lot of bad stories and a lot of heartbreaking stories around sepsis, but Sepsis Alliance is a good resource for you. So sepsis, not only will it kill somebody, but it also is very expensive to our healthcare system. Some stats that I pulled off of Sepsis Alliance: it's the most expensive condition to treat in the US healthcare system based on 2013 billing. That surprised me, $24 billion. And some of these other stats you can see here, it's increasing. The cost to treat a patient who's got sepsis is doubling. It's 6% of all healthcare costs, and hospitalizations that involve sepsis over 70% more expensive. So it's going to cost our healthcare system more to treat these patients, and patients lose their lives every day due to an infection that leads to septic shock or severe sepsis, organ failure. So let's look at some more cost factors. In 2014, looking at that 2014 time period, almost half of patients that died in an acute care inpatient setting, 48% had some degree of sepsis, whether it's simple sepsis, severe sepsis, septic shock, 48%. So I don't know if this speaks to antibiotic resistance, rapidly morphing bacteria in the community, whatever it might be. We're starting to see this more and more and more, and it's almost accounts for half of the deaths in our acute care setting. So CMS says, okay, this is costing a lot of money. Patients are dying. We need to have some sort of program in place. So in 2015, they put together the SEP1 based on surviving sepsis, sepsis management as part of quality reporting. They put together a tool and a protocol so that providers could do best practice based on experts and working with Henry Ford up in Detroit, some European physician associations, they put together this protocol. So in this particular slide we're looking at shows you the actions that need to take place. And this is a very simplistic graphical presentation of what you have to do to complete the bundles as part of this sepsis management program that CMS has. You know, you have to do a treatment, and then you have to have a particular reassessment, whether it's a lab value, whether it's an IV fluid bolus to counteract hypotension, repeat lactic acids, those types of things. So these are tools and protocols that you're most likely seeing your providers walk through. And I'll say they do a very good job in the acute setting, primarily the emergency room. Most ER applications, EHRs, are going to have a triage assessment looking for signs and symptoms that might indicate this patient needs to be in your septic protocol. However, what happens when they leave the ER? They move to that acute setting, inpatient setting, and they go to that nurse who has multiple patients, where it's not just one nurse with 1 or 2 patients, it's one nurse with 6, 7, 8 patients. Who's continuously monitoring that patient to make sure if they're showing signs of that they need to be in the septic protocol, that the clinician's notified, the protocol is invoked, and that they're doing the things when they need to do them. That's what we have to think about when we're talking about sepsis management, is who's doing what, which patient was identified. Remember, we started back in the discussion with identifying the right patients. Maybe when I was in the ER, I didn't have a fever over 100. I had a 99, but once I got to the floor, it moved up to 102.3. My blood pressure changed and my lab values are starting to change. Who's looking at all those data points to say, hey, I think this patient needs to be on our septic protocol? You've got to have that continuous monitoring and surveillance to be progressive, to have that strategy to prevent your not only not meeting the bundle and failing the score, but saving patients' lives, keeping them from sliding down that escalation chain. So how are we doing? I mentioned that this started in 2015 with data collection from CMS. So back in the fall of 2016, they did a presentation that says, hey, we've collected data for a full year. Now we want to unpack that and share with you. And this is one of the slides from that presentation. Shows we're not doing so well. That's the bottom line. 65% of those that sent in abstractions from their patients who were on the septic protocol did not pass all the measures. And it's an all or none type of measure. So about 35% met the bundle, completed the bundle, did the right thing at the right time for their patient. But 65% of us did not. I think that speaks to the complexity of the treatment algorithm, but it also speaks to the lack of continual monitoring and analytics to put all of those different data points together. And that's what I want you to think about today. That's where we're going. That's what we're thinking about in terms of your progressive strategy for your clinical patients. So the readmission that we were talking about earlier, they have claims data. Well, I mentioned with sepsis, it's all around abstractions. And for right now, we're doing 6 charts as a minimum for SEP 1. And SEP 1 is the protocol that we're using right now with CMS. There is a new version called SEP 3 that's out there. CMS has issued a statement that says, yes, we're quite aware of SEP 3. However, our protocol is focused on SEP 1. As we collect more data, as SEP 3 matures, we may make some changes to do that. So we certainly expect CMS to make changes not only with the protocol, but how do they get their data? Just like we're seeing with the readmission program, they're starting to ask for some of that clinical data. Maybe there's going to be in the future some change to how they get their sepsis abstracts, what data they're asking for, as they realize more and more of our providers participating in this program have a full EHR and can provide that data. Is that something around the 21st Century Secure Act with interoperability, sending that information into QualityNet? I bring that up just because we certainly expect CMS to continue to change their protocol, how they collect data. So it's important to whatever your strategy, it should include an application that can be customized and can be flexible based on the regulatory requirements. So this is a graphic that we use at iAtric Systems to talk about getting the right data to the right clinician at the right time so they can make those decisions. And this really applies very nicely to sepsis management. Identifying that patient. Remember, we said that's one of our clinical challenges. Identifying the patient who needs to be on that protocol, and then notifying the appropriate clinician so that they can make their evaluation. Then they can take appropriate clinical action, whether that's invoking the protocol, initiating a team response, so that the patient can have the right treatment at the right time. And then having the ability to take that information, the patient status, the actions that we're taking, and then have that for historical review so that you can have that continual process improvement available to you through analytics such as reporting and trending, historical views, reporting that goes out to executive leadership, physician leadership, nursing leadership, having that ability to do that. So when you're thinking about strategies, these are the points that you want to think about. Can I identify the right patients? Can I send notifications? Multiple ways to send notifications to allow my clinicians at the center of this workflow to make their clinical evaluation and use their best judgment based on the information I have presented to them to take that clinical action. And then can I continuously improve my process through my system? So data injections. Save lives, save times, cut costs. Just like that workflow was just showing, one of the key points is notifications. And we've all heard a great deal about alert fatigue. I get too many alerts. If you walk on any inpatient floor these days, you're going to hear bells and whistles going off, constantly alerting. So we're as providers, we tend to navigate a sea of alerts. How do I get that alert to the right person at the right time? Well, one of the ways iAtric Systems is attacking this challenge is getting that notification embedded into the EMR. So if I constantly go into my EMR and I go to one particular panel that shows me all of the information I want to look at around a patient, why not put something like an alert around a patient's sepsis status right there in the EHR where I'm interacting? Don't make the clinicians go somewhere else to find that information. Put it into their workflow, inject that data into their workflow so they can make their clinical decisions and actions right where they already are, where they are accustomed to interacting. So they can do those, make that evaluation and take the clinical action and do it before things escalate. So don't wait until a patient gets to severe sepsis or septic shock. How about when they're at SIRS, that systemic inflammatory response syndrome, which is a low-level form of sepsis? Or maybe they're at possible sepsis, that's their score. Why not alert someone then so they can take a closer look at that patient and make their assessment as to what they really need to do, maybe even prevent that escalation? So again, getting that information into the workflow, make it timely, make it appropriate to the right person. Don't make them go look for it. And then use all forms of telecommunication, whether it's a voice-activated interfacility system, it's a secure text, pager, any of that. Don't just use the EMR notifications that I'm gonna show you an example of, but also think about texting and voice notification all built into the same system. When you're looking and evaluating a system, look for those features. Can I interact with something like Imprivata or Voicera, as well as interacting with something like my Meditech EMR? Do I have that capability with a system that I'm looking at for something like surveillance around sepsis management? So here are a couple of slides that show you what I was talking about with injecting that data into the EMR. This is a Meditech 6X screen, and it's showing you one of the routines in the clinical record, and you can see in this upper right-hand corner it says severe sepsis. This little button is something that iAtrix system injects into the EMR, and it has different behaviors, different colors based on information it's collecting the system. So it's constantly looking at those vitals and those labs and those physician problems and documentation to do some machine learning to say, you know what, this patient looks like they're scoring severe sepsis. The clinician can then click on that and go look at additional information. So whether they're severe sepsis, septic shock, or any of those earlier levels of sepsis on that scale. So again, getting this information right where the clinician comes every day, multiple times to look at this patient, put that right there. I've got another example where I've got, this is a magic screen from the Meditech EMR, same type of button. It populates when they go into this clinical review. It shows up, and if it's negative, it just shows a green. If it's SIRS, it's yellow. Possible sepsis is orange. Red for severe sepsis, septic shock. You can make things blink. You can change the text. Be flexible with your system. Have that ability to get that information in front of the clinician without alert fatigue. So if it's green, if it's negative, that's great. But if it does start to indicate something, give them the ability to click on it, review that information, notify physicians if that's the appropriate action that needs to take place, so that then those alerts can then respond and say, yes, someone has been notified. Here's still the information, but don't do that continual alerting, so then it becomes something they ignore. So before we move on, I want to take just a minute to, we're going to pull some of these things together, and then we'll look at some strategies that some of the customers that iAtrix Systems has worked with on some of the feedback they've provided to us around some of the strategies that they're using around readmission and sepsis. But before we do that and walk back through some of these things at a high level, I want to see if Amanda's got any additional questions that have come in from the group.
We do have a question here. Going back to CMS and changes to the sepsis management program, how often do they make those changes?
That's a great question, and if I knew the answer to when I would expect CMS to make some changes, I could probably make some good Powerball bets as well. But based on their previous history, and that's all we really can go on, we do expect them to do another fall recap like they did last November in 2016. And then this opportunity will be for them to take 2 years worth of data and make their comments as to how this program is working out for the providers involved in this quality measure. You know, like I showed, there were 65 failing the bundle, 35 passing the bundle, that pass or fail. We certainly expect that to take place again this year. And perhaps we'll get some guidance as to where this program is going to move forward, and whether there's going to be changes to incorporate SEP 3, those types of things. But I would expect this fall to have the recap. We just had another version of the sepsis protocol. They can continually make some changes. I think we're at version 5.3 for that protocol, and that came out this year and this summer. So during the year, they do make some iterative changes to the program. So we certainly expect that to continue, and we do expect another recap this fall. And talking through that, I would say the most important takeaway there is have a system that can change with CMS. So if they're making changes several times a year or making some big changes once a year or every 2 years, have some flexibility built into your program so that you can make algorithm changes if that's something you need to do. I hope that answers your question. They do make them frequently, and we do expect something this fall as another recap, and maybe that will spur additional changes for Q1 2018, but who really knows? So thanks for that question.
Okay.
Any more before we go on, Amanda?
No, Mark, go ahead and go on. We'll address the rest of these at the Q&A slide at the end.
Okay, great. And thanks for reminding me, Amanda. I didn't mention that earlier, but we will have an opportunity at the end one more time. So let's put all of this together. We've talked a lot about readmission and sepsis, but really with any performance improvement initiative you have at your facility, you can apply these questions in this discussion around that initiative, whatever it might be. And these are things you have to always be thinking about. How am I measuring performance? What's my metric? What's my yardstick? Who am I comparing it to? Is it a federal regulation? Is it a pool of peers and physicians in my practice? What is my performance metric? What tools am I using? And am I using a tool that will not only survey and monitor, but also alert if something changes, if a particular threshold or a situation changes with a patient population? That's how you improve your outcomes and improve your quality, is not only gather the data, but analyze it and send alerts when things are passing thresholds, are not normal. How do you avoid alarm fatigue? Do you have the ability to turn off something that's sending me an alert? That's very important, especially to our physicians who get notified all day long, making sure those notifications are appropriate. And that flex button that I was showing you, it does give you the ability to indicate to the physician whether there is data worth going to look for. So if we just had a sepsis button there and they had to click it and go look at the report, look at the information that we present, and they're not sepsis or they're not possible sepsis, they're only going to click that once, ever. But if you indicate to them ahead of time, hey, there's information and we think this patient needs to be evaluated because we're scoring them at a certain level, that gives more validity and more competency to whatever system you're alerting with. Prefetch that information is what I'm saying. So how do you motivate staff to do the right thing? Do you use incentives? Or is there performance improvement incentives and built into contracts? As more and more physicians become employees, that's something that motivates just about all of us, is an incentive to do the right thing. But build that education into not just about a financial incentive, but also to your patients and your families in the community. Likewise, how do you hold poor performers accountable? If they're not clicking on that button, they're not invoking the sepsis protocol, they're not doing the order sets, how do you hold them accountable? Who enforces that accountability? Is it a chief medical officer? Is it a practice manager? What is the accountability at your facility? And of course, with any improvement process, you've got to have buy-in from your executive and clinical leadership, because they're the ones who are going to be doing that daily education, the influencing, making sure that your providers stay accountable and that they're moving forward with these regulations. Because if you're doing business today as a facility in the medical, you're going to have to deal with federal regulations. It's very few of us that have that opportunity to practice without some federal regulatory oversight, and mostly that's because they said, well, I'm not going to take Medicare and Medicaid. However, for many of us who have to deal with those are just part of doing business. So we have to build this continual process improvement and regulatory compliance into our strategies. So as I said before, let's take a look at some of the customers that Iatrix Systems has worked with around real-time clinical monitoring, that continuum of care that is surrounded by analytics and information given to the right person at the right time. This customer says not having to run reports, being able to see all the data on one screen and creating alerts based on selected criteria. Now that's power. So taking that information, don't make the clinician go look for it, aggregate it, normalize it, present it to the clinician so they don't have to go look for it, give them an alert when something passes a threshold. That's going to make a difference. Here's one talking about readmissions. Since implementing the system, a 30-day readmission at Saratoga hospitals has dropped by as much as 40%. So making sure your nurse navigators, your coordinators are understanding who's leaving the hospital, which patients have diagnoses that might incur a reimbursement claim penalty. Having that awareness is very important, and it makes a difference. Here's another one. The solution has dramatically changed the workflow throughout our hospital. Caregivers now have a real-time view of critical information at a glance, and that's key. At a glance, don't make them go look for it, and make it real-time. So you've made it this far in our presentation, and you're like, well, I wanted to see a demonstration. I wanted Mark to do something more than just talk about this. Well, I will reward your due diligence to say, look, on October 10th, we're going to have a demonstration to show you something specifically around sepsis management, where we're doing the surveillance, we're presenting that information, we're going to use that flex button and show you how that sepsis management application gives you all the tools you need that we saw in that workflow, from patient identification all the way through historical reporting and analytics. So you can register on our homepage, and that'll be October 10th at 2 p.m. Eastern. So I do encourage you, if you're interested, come back, join us for that session, and we would appreciate the opportunity to show you that in action. So now we're at questions and discussions, and so I appreciate any questions from the group here today.
Okay, Mark, we do have a couple here. The first one is, how does Imprivata work with messaging? I'm only familiar with the badging swipe in and out for access to Meditech.
Well, we do have some customers that are using the Imprivata, and I don't want to make this a commercial for Imprivata, but I just have awareness around how that's working for some of our customers. Our system sends out basically an email. It's handed off to Imprivata. They format that into a secure text, and then it goes out to the provider that way. So it's a text message sending out, taking a generic notification engine email internally, and then providing the security around it, which is something that Imprivata does quite well. I'd encourage you, if you work with Imprivata now, maybe you could ask them, and we'd be happy to provide you some information as well as how that's working for some of our customers. But basically, it's taking a notification, converting it into a secure text.
Okay, the next question is, who monitors the response to the alerts to see if they are being ignored? Is it IT, medical informatics?
That's a great question, and I think that's going to, and not to cop out on my answer, but that's really going to be based on your facility's best practice and who's going to take ownership of that. You know, on that last slide, when we were talking about putting it all together, that's going to be up to your leadership to basically decide who is going to have the best lever to make that change. So if you've got the ability from IT, and it could be collaborative, you know, IT is able to collect those statistics around alerting, notifications, and they're also with your clinical informatics folks, they can look at, okay, they were notified at a certain time. Here's when the order set was invoked through CPOE. All of those data points, that's going to be a collaborative effort. I don't think it's just one group. It's going to be your informatics group providing that information. IT can provide some information as well, and then you have to aggregate it, present it, get it in front of quality and clinical leadership to make those changes. So I think it's a collaborative effort, and that all is, again, going to depend on your facility structure.
Okay, the next question is, I saw Magic and 6X examples for the flex button. Does this also work with CS 566 or 567?
Great question. I didn't do that on purpose. That's just, I was just showing two examples, Magic and 6X. Yes, client server can certainly, you can invoke and embed that flex button example for sepsis management. And I'll give a quick commercial for flex button. It's not just for sepsis management or readmission monitoring. We've got a large number of clients who are starting to use that flex button to communicate with their HIE. So for example, they're in their ED and they want to know if this patient is there any information in their HIE. That flex button does a query, asks the HIE, is there any new information from this patient for this provider? And if there is, it changes color so that they do the prefetch for them. So the clinician doesn't have to waste their time going over to the HIE, doing the whole login to see if there's information there. The flex button does it for them. So yes, client server 566, 567, we can certainly do that same flex button integration and get injecting that data right there into the EMR. Great question.
Okay, thank you, Mark. Yes, all of these are great questions, and that's all we have at this time, Mark.
Oh, great.
Okay, well, I would like to thank everyone for attending our webinar today. As I mentioned in the opening, you'll have the opportunity to fill out a short survey to tell us how we did. We really appreciate you taking the time to do this. For your time, your name will be entered in a drawing to win a $100 Amazon gift card. And again, these drawings are held at the end of the month. Please follow us on social media and our blogs for healthcare IT updates and to interact with your peers. And if you would like more information, you can contact your Iatrix Systems account executive or send an email to info@iatrix.com. I'd like to thank Mark and once again thank everyone who took the time to join us. I hope you have a great day. This concludes our webinar.